talk about the free gingival graft around the teeth and around the implants. What's the indication? What about the technique? What's the difference between the both techniques? So I hope I can give you some hints and tips, clinical hints and tips for this technique today. First, it is not new. Free gingival graft is a new technique. It's not a new technique. It is most widely used simply. It's a predictable technique of increasing width of keratinized gingiva or covering the exposed roots from the specific areas such as lower anterior teeth. And this technique is starting from 1963 with using deepening in the vestibule and of root cavernous by neighbors et al. And at the end, there's a lot of modification of free gingival graft of using this part of the free gingiva around teeth or around implants. And there is no doubt about the importance of the keratinized gingiva either around teeth or around implant. Especially around implant, we need at least from 2 to 3 millimeters of keratinized gingiva around the teeth and around implant to prevent and to decrease the chance of peri-implantitis. Also, we need 2 to 3 millimeters of height and thickness of soft tissue around implant, which is called transmucosal zone, to decrease the chance of bone resorption. So there is no doubt about the importance of keratinized gingiva and the importance of soft tissue around teeth to decrease, prevent bacterial invasion and decrease inflammation and peri-implantitis and perimucositis. And this is 2 examples of importance of keratinized gingiva around teeth and around implants. As we can see in this photo, the lack of keratinized gingiva can aid in formation of dental plaque, decrease the efficiency of toothbrushing, increase the chance of gingival inflammation and calculus formation. Also around implants, the lack of gingiva help and increase the prevalence of peri-implantitis and lack of bone support. So in the OBG, you cannot, OBG is 2D, you cannot actually recognize the resorption of bone because you can see the OBG, the mesial and distal is excellent, but our problem in those cases in the bone, we as in those photos, reveal lack of soft tissue and frenulum attachment and lack of keratinized gingiva, which is increase the chance of peri-implantitis and gingival inflammation, chronic gingival inflammation, and formation of dental plaque, and may, with time, lead to loss of this implant. So today I will talk about the technique of a free gingival graft, about teeth and around implant, how we can improve the soft tissue and how we can improve the keratinization around teeth and around implants. Many cases, many situations we can use the free gingival graft around teeth and around implants, but actually using of free gingival graft around teeth is wider used or widely commonly used rather than around implants, because the only area or the 2 areas we can use the free gingival graft around implants is functional zone or functional area in the lower posterior area or sometimes in the lower anterior area. But we cannot use the free gingival graft in a static zone because this is not aesthetically will not be accepted. But around teeth there is a debate of this point. Okay, so you have to think in those cases when you have to use graft, a free gingival graft, or when you have to use a connective tissue graft. 2 dilemmas, 2 difference between both. And you have to bear in mind that the gingiva and the soft tissue around teeth is completely different around implants, because sometimes the teeth can survive without any keratinization if the patient can maintain the oral hygiene. But around the implants, the orientation and the parallelism of the collagen fiber is completely different. The soft tissue around implants is like scar. So there is a chance for the bacteria to invade easily, and there is a chance of inflammation to be present easily also. So you cannot compare the soft tissue around teeth and around implant with the same. It is completely different. So the indication is completely different. You have to consider in mind, you have to bear in mind there is aesthetic indications and functional indications. The free gingival graft is mainly or mainly used about around teeth and around implant for functional reason, not for aesthetic reason, as we can see in this case. So the principal consideration you have to consider first the area of the grafting. If the area is in a static zone, you cannot, it's not allowed, you cannot use a free gingival graft to hide the implant shadow or to hide the implant shadow or abutment shadow or increase the keratinization around implant or around teeth. Because nowadays, the quality of the soft tissue around implant and around teeth is more important for the patient and for us more than the quantity, the appearance, the morphology, the chromatic, the textural integration between the normal tissue and the grafted tissue is more important than taking a piece of the soft tissue and place it in the patient's mouth. So our aim not only to cover the root or increase the amount of soft tissue or increase the position of the keratinization. No, our aim mainly to give the patient good quality of soft tissue rather than huge quantity without any quality. Because if we applying the aesthetic score toll on this case, this is failure case, taking of free gingival graft to graft the soft tissue over the upper canine in the aesthetic zone in patient with high smile line. This will not be accepted nowadays by most of the patients. So what are the key factors for the soft tissue graft success? The ZUR in 2018 classify some of these factors related to the patient, like smoking, the age of the patient, the oral hygiene, the systemic health. You have to select your case properly. You have to consider all of these factors that related to the patient and other factors related to the site related factors, amount of keratinization, site of defect, a plaque accumulation, clinical attachment, vestibular depth, the defect localization, all of these factors. The other factors related to the clinician, related to the technique itself, the blood supply, preparation of the recipient site, the incision design, the operating skills, the flap tension, the flap thickness, the graft volume, all of these factors integrated and have a very high impact in the success of the graft. So first, as I said, you have to select your case properly. You have to select, there is no doubt in the category of B, if there is no lack of keratinization, high frenum, loss of interdental soft tissue attachment, loss of papilla, all of these factors are in lower posterior functional zone, no doubt about using of the free gingival graft. While in the C category, if you localize the gingival recession or peri-implant soft tissue defect in a static zone, it is not indicated for at all to use the free gingival graft about those cases. While in the category of A, around teeth and root recession, to cover the root, it is a point of dilemma. So selection of the case, starting of the selection of the proper situation, a proper site, as we can see in this case, the severe crowding, the tooth is completely outside the bone housing. If you use the free gingival graft or any kind of soft tissue, it will not succeed, sorry, because the tooth is outside the bone housing. This case indicated for orthodontic treatment first, to align the teeth and bring this tooth inside a line of this teeth and bring the tooth inside the bone housing that will improve the root exposure, the exposed root, improve the keratinization. After that, after 6 months from the orthodontic treatment, from the completion of the orthodontic treatment, you can use any kind of soft tissue graft around those teeth. Or in this case, severe crowding, labially positioned. If the previous dentist requests for the patient to do CBCT, they send the case to me, Dr. Abdusalam, please graft this case. No, I cannot graft this case because as we can see, the tooth is completely labially outside the bone housing. This case indicated for orthodontic treatment first. In other cases, if you want to know, you have to see the tooth from the occlusal view. If you see the occlusal view, because sometimes the orthodontist doing tipping for the root, bring the crown inside and take the root outside. This is also very common problem during those cases. You have to consult the orthodontist about this point to tipping the root inside and give complete alignment for the entire tooth inside the bone housing. We can start with those two cases of class 4 better classification on the left side and lack of keratinization around the implants on the right side. And about the surgical technique, we start with infiltration anesthesia from away from the graft site with 1 centimeter at least. Slowly deposit the local anesthesia. Don't allow to do any ballooning or any destroy any the anatomy of this area. Also in the palate, you have to inject your anesthesia away from the grafting site. You can apply some pressure before you're injecting some amount of local anesthesia. And after that, you have to determine your target. Is your free gingival graft is used to increase the width of keratinization, or your gingival graft is used to cover the root? The technique is completely different. So you have to determine from the first your target is increasing the width. If your target is increasing the width, so you will keep your incision completely away from the interdental papilla and keep your incision at the mucogingival junction and place your graft below the mucogingival junction, because your aim is to increase the width of keratinized gingiva. After that, you will do, maybe you will do 2-stage technique and you will do coronary advanced flap after 3 months. Or your target to cover the root coverage. If your target cover the root coverage, you have to do depitalization of the mesial and distal papillae and place and extend your graft 3 millimeter on mesial side and 3 millimeter on distal side, as we can see. This is the design. This is the design. This is the design actually to cover the root. If you're going to cover the root with the free gingival graft, start your incision at the mucogingival junction, extend the horizontal incision 3 millimeter mesial, 3 millimeter distal, 2 short vertical release from 4 to 5 millimeter, expose at least 5 millimeter of periosteum apical to the recession, and place your graft at the base of interdental papillae. If you want to cover the root. If you want to increase the keratinization apical to the recession, don't do any depitalization for the papillae. Just keep your flap like this: 1 horizontal incision and 2 short vertical, and place your graft here. As we can see in this case, if you want to increase the keratinization, it is just 1 single horizontal incision. First, you have to be parallel to the mucogingival junction. After that, place your blade parallel to the bone to do partial thickness flap. This place the muscle down, and that's it. And place your graft here and fix it here. If you want to cover the root, you have to do depitalization for the mesial and distal papillae to place your graft here at the base of interdental papilla to cover the root. And you have to expose at least 5 millimeter of periosteum apical to the recession. This is very excellent split thickness flap. You have to move. This is one of the key actually of the success of free gingival graft. You have to move the muscle attachment down. Don't allow for any muscle to be attached at the bed, because if there is any mobility of the lip underneath the graft, this is one of the causes of the failure of the graft. You have to keep the muscle down. You have to do your split over the bone. How you can do that? Keep your blade over the bone and move it over the bone. Move. When you move your blade, when it's over the bone, it will cut all the muscle and move it down and keep just the periosteum over the bone, as we can see in this diaphragm. Okay, this is the technique of covering the root. You can do a depitalization of the roots. This is the first incision. You have to be horizontal, parallel to the mucogingival junction, as we can see in this video. Now, the first incision, extend 3 millimeter mesial, 3 millimeter distal. Keep your blade parallel to the bone. Move the muscle attachment down, because in this technique we aim to cover the root. You have to do depitalization for the mesial papilla and depitalization for the distal papilla with using the blade. After that, you deal with the exposed root with curate, manicurate to remove any necrotic cementum and any smear layer. Apply the EDTA or Mesial for 2 minutes and measure the site, the recipient site, and go to the palate to harvest the graft. Sorry. This is the split thickness. There is no difference actually in the split thickness between the teeth and between the implants. But the point, when there is lack of keratinization on the buccal side and there is some of keratinization on the occlusal side, you can do your incision on the buccal side and do split thickness over the implant heads and move this keratinization on the lingual side. It is lingually, epically displaced flap. And place your graft on the buccal side. Because in some cases, there is just 2 millimeters over the crest. In some cases, you can do free gingival graft on the buccal side and the free gingival graft on the lingual side. But I want to give you some hints of keeping this technique more simple. If you have 2 millimeters, just 2 millimeters on the occlusal side, on the crystal side of keratinized gingiva, do those 2 millimeters and move it on the lingual side and place your graft on the buccal side. Actually, the same technique, horizontal incision, short vertical, deep-talized the papilla, mesial distal, deep-talized the papilla in between to the lingual side, and you have to do suturing, vestibuloplasty. This is normal technique of Kazanchi technique, suturing the muscle attachment down with absorbable suture to keep the muscle down and give the chance for the graft to be fixed and sutured. This is the technique that I said now. Do your incision on the buccal side and move those keratinized gingiva over the implants and over the occlusal side to the lingual side to do lingually, epically displaced flap. Okay, this is another split thickness flap. This is another 2 split thickness flap, either around teeth or around implant. This is the same. There is no difference. The only difference, as I said, if you have just 2 millimeters on the crystal side, move it on the buccal side, move it on the lingual side. And deal with the root either with fine pair or with the curate. And this is not mandatory step, actually. I don't like it. I don't like to do it in every case. I have to do it just in posterior area to do vestibuloplasty. To take this muscle and suture it down with absorbable suture. It is not mandatory. You can do it. You cannot keep the flap down free without any kind of suture. As like, there's not the difference. There's no difference. And go to the palate, harvesting the graft from the palate and safety zone. We have millimeter the 6 millimeter width of keratinized gingiva or of free gingival graft. You don't need to go to the palate for 8 and 9 and 10 millimeter. No need to do that. The length, it depends. You can take the free gingival graft from the 8 to the 4, to the first premolar. The length, we don't have problem in the length. But in the width, you have to keep the width from 5 to 6 millimeter. You don't need more. You have to keep 2 millimeter. First, equalize the area, distal and mesial, and keep the inferior cut at the end. Okay? This is the first, the second cut, and this is the third cut. You can take the graft from the palate. This is the first cut. You have to be perpendicular on the palate, not to the bone. Just to do it, the depth, it depends on the flap thickness. How many millimeter you need to harvest? 0.5, 1, 1.5. So the first incision, you have to do just mucosal incision, perpendicular to the palate of the blade, go parallel to the palate to split the epithelium and part of the connective tissue away from the connective tissue and the remaining part of the periosteum. Okay? If you see the fat in the graft, this is not good sign. This is not good sign. You are going too much deep to the palate. So the graft thickness, it depends on if you want to place the pre-gingival graft over the root coverage. It is indicated to be thicker, more than 1 millimeter. If you want to increase the keratinization, it is indicated or it is preferred to be less than 1 millimeter. So the less thicker, the better viability and better healing. When the graft is thick, the chance of failure is high. And this is actually the thickness. If we want to, you can harvest from 0.5 to 1.25 if you want to take all the connective tissue with the epithelium in case of root coverage. Okay, start with distal, occlusal, first perpendicular, after that parallel. You can take this part of the graft. There is no any bleeding, there is no any healing is good, pain is less because we didn't go deep. This is okay technique. Like we like harvesting the connective tissue graft. Harvesting of free gingival graft or connective tissue graft is the same. Is the same technique. The only difference in the connective tissue, after harvesting this part, we take it out the patient mouth and we deepitalize the epithelium. We only harvest, we only keep the connective tissue. The length we can harvest even 20, 30 millimeter of the graft. The length, we don't have any problem in the length. And this is the harvesting technique. Start with perpendicular to the palate, distal mesial release. After that, to place your blade parallel to the bone. Keep the inferior cut at the end, and take the graft in one piece without any tearing. There is no any bleeding because the graft is very superficial. I prefer to take first distal suture to control the bleeding and keep the knot inferior, not superior. And cross suture is over the remaining exposed part. Cross suture is to cover the exposed part. After that, there is no any manipulation of the graft just to remove just to remove the fat layer. If there is any fat layer, we have to remove it and keep uniform thickness of free gingival graft. Don't remove the epithelium if you want to use it as a free gingival graft. Okay, after that, this is the design of the graft, either around teeth or around implant. I designed it in inverted T-shape. I did a lot of cases of this design and will publish it soon, inshallah, in the literature. There's this specific requirement for this technique and specific indications also. Okay, so finally, what about the fixation of the graft? The fixation of the graft, actually, this is the healing before and after. This is the before, and this is after, then this is before, and this is after. And this is the graft. And the graft before the suturing, the graft position, you have to place your graft at the base of interdental papilla, not to the crest, because this part and this part will not survive. So you have to keep your graft at the base of the interdental papilla. And about the suturing, we suturing the graft and suturing material. I prefer to use 6-0 Prolene or 6-0 Vicryl. 6-0, 7-0, sometimes 5-0 is accepted. First, you have to stabilize the graft with mesial and distal sutures. Stabilize the graft mesially and distally. Very simple interrupted sutures, mesial and distal. And the most important suture is the periosteal sutures around teeth. And you have to keep the sutures in the periosteum down. If you not keep the periosteum down, good thickness of periosteum, you will not perform this type of suture technique. So take your time and split thickness. You have to keep adequate layer of periosteum over the bone to facilitate the suture. Okay. So what's that? Okay, simple interrupted sutures at the periphery horizontal mattress to fix the graft in horizontal direction, and this is the most important one, periosteal sutures to fix the graft, because this is the second key of requirement for the free gingival graft to be successful is the fixation. You have to keep intimate contact between the graft and between the periosteum. Don't allow for the graft to move, or don't allow for the graft to place it over the muscle. You have to fix it properly. This is the second key of success. You can use the Vicryl, you can use the Prolene. I prefer to use 6-0 Prolene or 5-0 Prolene. I didn't use the Vicryl. Maybe I use the Vicryl at the vestibule to do vestibular deepening. Okay, a lot of sutures, as we can see, this is a lot of sutures, but you can keep it simple, just to do simple interrupted stabilizing suture at the mesial and distal, and do periosteal sutures for the remaining parts. This is very important. When the needle is entering to the periosteum, you have to take you have to touch the bone. When the tip of the needle touch the bone, you can circle the needle and take the periosteum. Don't take some part of the periosteum or very thin superficial part of the periosteum, because the tearing is very, very easy to occur in this case. So you have to keep the tip of the needle perpendicular first. When the tip of the needle touch the bone, you have to move your needle to take the periosteum and take it out. Okay, this is stabilizing sutures, mesial and distal, occlusal sutures. This is not important sutures, just for stabilization, mesial and distal. I did this case under the microscope, actually. This is the important one. As we can see, this is the important one. Your needle should engage the periosteum, not the muscle, not the graft. The suture should be over the graft. You have to engage the periosteum. Under the muscle, you can do it parallel, you can do it cross, as you like, and keep the knot over the graft. Okay? Many cases of fixation of that in the palate, you have to do cross sutures, you can do stent, you can place any kind of local hemostatic agent. In this case, as I placed gelatin sponge, I did one cross sutures with the distal one. I prefer to do this distal one to control the hemostasis. You can place periacryl or any kind of material over the graft, or gel or hyaluronic acid, or PRF, or any kind of material over the harvesting site. And this is very important, because some of the students asking me in the follow-up, and some of my colleagues that helping me in such cases, after 1 week, when they saw this white color over the graft, they say to me, "Oh, Dr. Abdusalam, your graft is failed." No, I said to him, no, this is not failure. This is normal healing of the graft. This is normal color. This is the necrosis of the epithelium of the graft. But underneath, when you take out all of this necrotic epithelium, you can see the new blood vessel. You can see the new vascularization after 1 week, after 2 days, after 3 days. After that, the complete epithelium or epithelialization by 14 days, and complete keratinization after 1 month, or almost 1 month. And the second point is very important. We place the graft underneath the recession, and we keep the graft for creeping, because the creeping starting from 1 month to 1 year, from 0.3 to the 9 millimeter in the literature. It depends on the case, and depend on the tooth, and depend on many factors. And this is the healing of the palate after 1 week. This is the healing of the palate after 1 week and after 2 weeks. And this is another case of adding and improving the keratinization of the around teeth, as we can see, adding some restorative material around teeth to help the soft tissue to grow and creep with time. Also around implant, we can deal with the exposed threads. Treat it first and place the graft underneath this implant head and fix it properly. We can also use extension technique with free gingival graft at the same time, taking 2 separate pieces of graft and fix it properly around the abutment. This is another case also of split thickness around implant. You can use the graft also down, not over the abutment, down, and keep with time for the graft to creep and cover this metallic part. This is another case of GBR. This is the case of from beginning, lack of keratinization. We open the flap, placing implant, doing GBR. At the second stage, we're placing the healing at the same time, placing free gingival graft. And this is the case before, and this is the case after healing, after 2 months. Also around teeth, you can use the free gingival graft to cover the roots. Also, you can use the free gingival graft before orthodontic intervention to improve the keratinization and improve the patient oral hygiene. This is the creeping effect. This is the end, at the end of the orthodontic treatment. You can see now the amount of keratinization and the growth of the interdental tissue between the teeth. And this is the X-ray before and after. And this is another case of orthodontic intervention. This is after the grafting. And this is before and after the orthodontic. And this is at the end of the orthodontic treatment. We can start with this case and would end with this result. So the last thing, the common reasons of graft failure. There is many factors may cause the graft failure, but the 2 main important factors is improper adaptation of the graft and inadequate graft fixation. This is the main 2 factors of, because in those cases for me, this is from maybe 5 or 6 years ago. In this case, I didn't extend the graft properly. I placed the graft over labally positioned canine, so the graft is complete outside the housing of the bone, so the graft is failed. The other, I placed the graft is too much superior. Most of the graft, the superior part of the graft is failed also. That's why you have to determine from first your grafting either to cover the root or to increase the keratinization. I have my special kit with Devomed company. I'm working with this kit for the soft tissue and with the crown lengthening cases. And waiting to see you next in Morocco, I think 2020, 2022, Dr. Ali, with Dr. Ali in the diploma of international implant with the DGI. And thank you for my team who's working with me, working together, everyone to achieve the better result. And thank you very much for your intervention, for your attention. Thank you very much, Dr. Ali, on your kind invitation. Thank you, Libyan Dental Forum. Thank you of all Libyan doctors and students, or all Libyan colleagues on watching this lecture. I hope I can give you some hints and tips about using the free gingival graft around teeth and around implants. Thank you, Dr. Ali. Thank you very much.